Hello, my name is Avery Fuller. I am a DNP student at Jacksonville State University. My program is titled No More Strokes for Healthier Folks. It is a primary prevention community program designed to reduce stroke risk in people ages 40 to 50. These are my objectives. The overall goal of this program should be to educate those susceptible to stroke, thereby leading to a reduction in the overall incidence of stroke. During this presentation, I will be defining stroke as well as differentiating between the types of stroke, as well as identifying risk factors and explaining signs and symptoms of stroke. Then we will delve into my primary prevention program and explain how I will implement that program into the community as well as evaluate effectiveness of it. Furthermore, I plan on explaining the role that I will be taking as a doctorate prepared nurse leader in the program. So what is a stroke? This is also called a cerebrovascular event. Depending on the type of stroke, blood is either blocked from reaching an area of the brain or blood flow is significantly reduced to that area of the brain. Either way, brain death occurs, and it can occur in minutes. Depending on the severity of the stroke, it can have lingering symptoms for years and greatly reduce mobility. So here are the different types of strokes. Ischemic is the most common stroke, and it involves a blockage or severe narrowing of the vessels in the brain, not allowing blood to pass through. It causes that area not to be vascularized. A hemorrhagic stroke involves the brain not being vascularized due to blood pouring out of a vessel. And then this last is a transient ischemic attack, otherwise known as a TIA, which is a temporary blockage in the brain. These are warning signs that an actual stroke might happen soon. Although the symptoms do resolve quickly, it is important to seek medical help right away, as it can mean an actual stroke is just on the horizon. This is an illustration of the different types of strokes. On the left here, you can see an example of a hemorrhagic stroke, and on the right, you can see an example of an ischemic stroke. So let's talk about stroke prevention. So prevention and treatment of stroke is dependent on the pathology of the stroke or what type of stroke it is. So part of education for clients should always be to identify what type of stroke the patient is most at risk for. For example, a person might be at risk for stroke due to a history of atrial fibrillation, or they might be put on a blood thinner for that condition or for any other condition. So they will be put at risk for hemorrhagic stroke, and they need to be educated on accident and trauma prevention. Conversely, a patient who has a history of hyperlipidemia, has a diet high in cholesterol, has uncontrolled hypertension or uncontrolled diabetes mellitus, they will be more at risk for an ischemic stroke due to a blockage in the brain and plaque buildup. So here are the signs and the symptoms of stroke. You're going to be looking for extreme weakness on one or both sides of the body, things like slurred speech. Early recognition of these stroke symptoms is essential in getting help for the patient. These are a few of the more common signs of stroke. Patients might have the obvious weakness on one side of the body, or they can just have difficulty performing their activities of daily life one day. These include swallowing, walking, picking things up, talking. Here is an acronym that is common in the medical field to kind of remember the symptoms of the stroke. And though this is going to be a primary prevention program, in order to understand the way stroke impacts life, I think that this is very important to go over. So this is a more of an updated mnemonic. You're going to look for a weakening in balance, a asymmetry of the eyes, the face. Your arms will be weaker, especially one side. You might have some slurred speech. And then the T stands for time. You want to track the onset of symptoms so that you know what to tell the medical professionals just in case they need to do TPA or something like that, which we'll talk about. These are a few of the treatments of stroke. In the case of ischemic stroke, thrombolytic therapy or TPA may be used to lyse the clot that's causing the stroke and restore blood flow. Administration of this drug primarily depends on when the symptoms started and how quickly the patient found medical help. In fact, one study entitled "Why Are Stroke Patients Excluded from TPA Therapy" found that in one hospital, 27% of patients who came in received TPA because the other patients weren't candidates. They either had an unclear onset at the time of symptoms and when they started, or they had mild or resolving symptoms by the time that they were considering administration. In addition, a rehabilitation program is usually recommended to stroke patients after initial treatment and stabilization. The earlier the intervention, the more confidently ADLs can be performed, but even though they do sometimes go into these rehabilitation programs, it doesn't always mean that they're going to be restored to full function. The best treatment for a stroke, like anything, will always be to prevent it from happening in the first place. So while not all risk factors can be eliminated from someone who may have a stroke, many strokes can be preventable. So let's talk unmodifiable risk factors. These risk factors are similar for both types of stroke. These are things like age. A stroke risk continually increases after the age of 55, with the average stroke being around 69 years old. Gender can also play a role in who is at risk for stroke. Women are at increased risk for stroke when they are younger, and as they age, it kind of levels out and they become at the same risk for men. Studies suggest this can be due to pregnancy or hormones that we have and the way our body holds on to fat. Race also plays a huge part in determining risk factor for stroke. African Americans, Hispanics, and Native Americans are all at increased risks, possibly due to a higher number of comorbidities that they are susceptible to, such as heart disease, hypertension, and diabetes. Furthermore, any kind of cardiac disorder, but especially atrial fibrillation, can put someone at an increased risk for stroke due to the thickening of the blood in the atria and the fast heart rate. And lastly, family history should always be included in any stroke assessment. So these are the more modifiable risk factors. High blood pressure or hypertension is defined as any blood pressure over 120/80. Even if you have a history of high blood pressure and your blood pressure is within normal limits now, you still are at risk for stroke. Therefore, controlling blood pressure is essential for decreasing your risk. With hyperlipidemia, a buildup of plaque in the arteries can put patients at increased risk for ischemic stroke because it can block that blood supply to the brain. Poor diet and lack of activity can only exacerbate this risk. In addition, diabetes, both types 1 and type 2, can put one at an increased risk for stroke, especially when it's uncontrolled. So these are the different levels of prevention. Primary is what my program will mainly focus on. This is true prevention of the disease. They don't have the disease yet. We're just trying to prevent them from getting it. Secondary prevention also involves quick detection of symptoms. In the case of stroke, this would be the BFAST acronym we just went over. And then finally, tertiary would be things like rehabilitation, where the main goal of this level of prevention is to restore them to their best functional ability. So this is my focus for our primary prevention plan. Primarily determining risk and then to try and get those modifiable risk factors under control. So the purpose of this is to educate people who are at high risk on reducing their risk and to make them think about their self-assessment. The design there is going to be 10 to 15 people who will meet and be assessed by our team. Things like vital signs will be taken, home medications. On my next slide, I will dive more into that. There will be several sessions going over a course of a day, and then a self-screening tool will be sent before the sessions and after the sessions to see how well the sessions affected their life. So our class sizes are going to be about 10 to 15. Ideally, we should have 40 to 50 years of age, just because that stroke risk increases after age 55. Ideally, we would like to have someone who is at high risk for stroke. So our interdisciplinary interdisciplinary team will include me as the leader, the doctorate prepared nurse practitioner, a dietitian for nutritional education, as well as vascular nurses who will provide educational sessions, and BSN students who will take part in the free screenings. So this is my plan of study. It will begin with the BSN students taking a family history and a very thorough physical assessment. Then the participants will be asked to complete a self-assessment or a stroke quiz. After that, icebreaker activities in the sessions will occur. And then at the very end of the day, we will focus on putting it all together or helping them develop their own goals and their own techniques in order to lead a healthier lifestyle. What I really want to do is to resolve the risk factors, those modifiable risk factors, until the risk of stroke is significantly reduced. We will mainly focus on monitoring blood pressure, how to do that, and taking medication as appropriate and prescribed, strict smoking cessation, and exercise to improve cardiovascular health, as well as keeping doctor's appointments. The dietitian will focus on cardiovascular, fruits and vegetables, whole grains, protein, low sugar, low cholesterol, and then smoking cessation will be another really big session. So what we can do is not only explain why smoking increases your risk for stroke, but also provide information on stop smoking aids. The final session will be talking to your doctor and tips for doing that, kind of bridging the gap between the patient and the doctor and giving them the confidence to broach this situation with their doctor at their yearly appointments. This is a copy of the self-assessment tool that I would ideally like to use before the session, 2 months after the session, and then 6 months after the session. This is from the American Heart Association and the American Stroke Association. So, at the end of the program, I would like for the participants to discuss 1 to 2 new things they learned at each particular topic, as well as have a written plan on how they will implement these risk reduction activities into their daily lives. 2 months after the session, another self-assessment tool will be sent out, and then 6 months after the program, I would like another self-assessment tool to be sent out to see if they were able to reduce their risk of stroke at all. Incentives will be included for those who return surveys. So this is my role in the program. My role is to oversee the project. I will be responsible for choosing the team as well as overseeing and reviewing their material that they are going to present, and then designing and compiling data from the pre and post self-assessment. So, benefits to the community. 17% of death from cardiovascular disease was due to stroke in 2018. It is one of the leading causes of mortality among cardiovascular diseases. These are from the Center for Disease Control. Out of the 795,000 strokes that occur each year, 610,000 of these are people that are having their very first stroke. So any prevention plan should be developed to people who have not had a stroke yet or who are at an increased risk for their first stroke or second stroke. So these are the APRN competencies that we will include. Project management. So the APRN should be able to oversee the workload for projects like this and facilitate interdisciplinary work and delegate when appropriate. Communication is important, not just to be able to communicate between specialists and delegates of the project, but to facilitate communication between the team presenters and the participants. So this is a brief summary of everything that we went over today. We defined stroke, saw the warning signs of stroke, discussed the risk factors for both types of stroke, and described ways to decrease the risk of stroke. We've also outlined a primary prevention project aimed to reduce the risk of stroke of people in the community, primarily ages 40 to 50, and we've outlined the role of the APRN in this project. here are my references that I've done. Thank you very much for your time.